and Dr. Michelle Morse, to my right, who's the Chief Medical Officer and Deputy Commissioner for the Center for Health, Equity, and Community Wellness at NYC Department of Health and Mental Hygiene. And finally, we have Zahirah McNatt, who's the Assistant Commissioner for the Bureau of Brooklyn Neighborhood Health and NYC Department of Health and Mental Hygiene.
Good evening. In 2011, I was working in a rural hospital in Haiti, and I had the privilege of taking care of a 16-year-old young woman who 4 weeks prior had just had her first baby boy, who was doing well and healthy at home. She was lying in her hospital bed wearing a yellow gown in our small women's ward in Las Caobas, Haiti, and she was surrounded by elders with frowns on their faces. At home, she had become progressively more short of breath, so much so that she had to come into the hospital, where she was diagnosed with a preventable complication from her recent delivery, severe heart failure. Though she was improving with treatment, her oxygen levels continuously got lower and lower and lower, such that I had to make the very difficult decision to transfer her on an incredibly unpredictable 2-hour ambulance ride to a hospital with a higher level of care and an intensive care unit. I will never forget her fear and mine. Her complication was preventable. In fact, heart failure as a result of delivery is a very common preventable complication amongst Black women around the world. And in fact, Haiti has the highest rate of maternal mortality in the Western Hemisphere. So when she got to the intensive care unit, got great treatment, and recovered and was able to go back home to care for her newborn son, both of us were relieved. The conditions that created her preventable complication are human-made and can be changed, undone, and transformed by people, communities, and government. So I myself am from Philadelphia, where I was raised by my mother, who herself is someone who believes deeply in government, is a public school teacher, and raised us to be incredibly proud about being Black in this country through museum trips to Black history museums in the summertime, through books, through, of course, all of the stories of Black success. And my mom inspired my passion for knowledge, and she taught me how to learn. And it's that really led me to an interest in a career in medicine and to becoming a physician. In medical school back home in West Philadelphia, which is where I grew up, I was the only medical student out of 600 medical students at Penn Medical School who was from the community where the medical school is located. In the hospital, I witnessed the impact of racist beliefs amongst the hospital staff on access to care in the hospital and on the actual support that they received in the hospital. And I saw the parallels in how care for my patient in rural Haiti was also impacted by centuries of racism, colonialism, and extraction, quite frankly, because the world felt that it needed to punish Haiti for becoming the world's first ever successful revolution of enslaved people and first ever independent Black republic. Yes. Centuries of oppressive policies and systemic racism have led to the tragic health inequities that we all see today. But one of the most tragic is the absolutely unjust and preventable death of Black women and birthing people in delivery and labor. In a nation with the level of resources that we have here in the United States, this is particularly unconscionable and unjust. This is happening right here, right now, where we stand in New York City. And my colleague, Dr. Zahirah McNatt, knows this as a native New Yorker.
I grew up in the Lower East Side in the 1980s and 90s. A tight-knit, largely Latino community, really centered in communal support, but also hit hard by substance use and HIV, and then gentrification and forced displacement, and a myriad of ways or attempts at renaming and rebranding the neighborhood. My mother was strict. Stay out of the street. She was proud. Learn everything you can learn about yourself. And she was meticulous in just about everything. In my formative years, she avoided healthcare because of price and racism. Occasionally, she attempted to navigate the Medicaid system and would turn away from government support because of the injustices and because of the shame placed upon people in need. Early on, I understood that our own individual behaviors were not the only reason for our health outcomes. I didn't have the language for it then, but the words would come later. Words like colonialism and structural racism. Policy contexts like redlining and healthcare segregation. I didn't really know at the time, but my lived experience was preparing me for a career in global public health. And my undergraduate degree in Africana Studies and my mother's love for Black history was helping me center justice. I have focused on many subjects in my career, whether it is health for folks who have been displaced, it is the intersections of chronic disease and mental health, or it is the concerns of healthcare worker education. But maternal health and maternal death is one of the grossest inequities in New York City and across the globe, because it's symbolic of how little value we place on Black girls and on Black women and on Black birthing persons. I still somehow think the future is very bright. I believe this because all over the globe, folks are doing some of the most dynamic and interesting and amazing work at tackling maternal health and reducing mortality. Nations like Rwanda, Ethiopia, India, places where I had the opportunity to live and to learn and to work. And while these nations still have high death rates, the improvements they've made are impeccable and worthy of study and replication. Progress driven by community health workers, by male involvement, by technology, and more. And perhaps most importantly, progress driven by naming discrimination, naming injustice, naming violence that happens in healthcare settings, and then choosing to stand against that. Rwanda is where I learned about political leadership that changes maternal health. Ethiopia is where I met community health workers who participate in pregnancy and birth and the postpartum experience. And India is where I saw vast investment in communities that were historically marginalized. New York is different, surely, but we require a lot of humility in order to learn from environments that may be unfamiliar to us. And so we have an opportunity to center community-based solutions and to center the folks who are the most marginalized. And in this case, that's Black women and birthing people. A radically different future for birth is possible for us, one that is safe and one that is dignified and one that is joyous. And I know Michelle and I have learned a lot along the way, and I'm honored that we get to work with a whole host of other folks across the city to tackle the elimination of birth inequities in New York.
For both of us, our journey as leaders has been about centering what our mothers taught us, building global solidarity across the African diaspora, and holding institutions accountable. As we look to the future, we don't need to reinvent the wheel. We need to implement what we know works, such as, number one, universal access to doulas and fair pay for those doulas. Number 2, reforming our payment policies to incentivize healthcare instead of sick care. Number 3, centering the margins, which means designing our interventions for the communities that have suffered the most unfair and unjust outcomes, which in this case is Black women and birthing people. And we have to use data for action instead of just analysis. These solutions are within our reach. Facing the uncomfortable truths that we are far from equity is a critical step along the way in progress. We imagine a future where Black moms and birthing peoples not only survive, but thrive and are present for their families, their communities, and their neighborhoods. Join us in our resolve to a future in New York City and globally where becoming a mother is safe and equitable.